You know that feeling when your body just uh, throws you a curveball, maybe a sudden kind of unexpected tightness in your chest, perhaps?
Hmm.
Or maybe you notice some swelling in your legs and you can't quite figure out why it's there. It doesn't seem to go away.
Right. It's easy to just brush those things off sometimes.
Yeah, but what if there's signals, quiet little alerts from, well, the incredible engine inside you, your cardiovascular system?
It's really fascinating how things that seem totally separate, these isolated incidents, can actually be deeply connected within our cardiovascular health.
Definitely.
And today we're going to take a really in-depth look. We're aiming to sort of dissect the information we've got here.
Okay.
Our goal is really to connect the dots between what might feel like random symptoms and, the underlying mechanisms actually at play. From the tiniest changes in our arteries, really microscopic stuff, to the big picture effects on our major organs.
Exactly. And we've pulled together a pretty comprehensive set of materials.
Hmm.
Um, Everything from detailed medical blueprints, looking at arterial problems, heart conditions,
Yeah, quite a range.
to even how these issues can kind of ripple outwards, affecting, say, the gut and the liver. Now, we know getting into medical specifics can feel a bit overwhelming sometimes.
It definitely can be. Lots of jargon.
So our mission here is to pull out the really crucial insights for those aha moments that bring clarity, hopefully without getting too bogged down in complicated terms.
Hmm.
Think of us as your, well, dedicated guides through this really intricate but vital system.
And as we delve deeper, I think you'll really see just how interconnected everything is.
Yeah.
We often talk about different parts of the body like they function totally independently,
Right.
but a disruption in one area can have really significant and sometimes pretty surprising consequences elsewhere. So our aim is to provide a detailed yet hopefully accessible understanding of these disorders and their potential effects.
Okay, let's really unpack this then, starting right at the foundation of our circulatory system, our arteries. And right away, the blueprint makes this key distinction between atherosclerosis and arteriosclerosis. They sound similar,
They really do.
but it's important to get the difference, isn't it?
That's absolutely right. Arteriosclerosis is like the broader term. Think of it simply as the hardening and loss of flexibility in your arteries.
Okay.
Sort of like old rubber hoses getting stiff and less pliable over time.
Yeah, I get that image.
Atherosclerosis, though, that's a specific type of arteriosclerosis. And it's the one most directly linked to things like heart attacks and strokes.
And atherosclerosis is really all about that plaque buildup. The info we have here describes how it often kicks off with some kind of damage to the inner lining of an artery, the endothelium.
Yes, that initial injury, it sets off a whole cascade of events, a real chain reaction.
And cholesterol plays a big role here, particularly LDL cholesterol, right?
Exactly. What's particularly interesting and kind of central to this is the role of LDL. When certain immune cells, macrophages, encounter this LDL cholesterol in the artery wall, they essentially engulf it, they eat it up, and they transform into what are called foam cells. These foam cells are literally the building blocks of that atherosclerotic plaque.
Ah, okay.
So a key insight here is that this silent buildup, driven largely by cholesterol and inflammation, is the underlying cause of so many serious heart problems. Addressing cholesterol levels and inflammation, too, early on is just crucial.
And it doesn't just stop with those foam cells forming, does it? The smooth muscle inside the artery wall starts to thicken up,
Right. It's hypertrophies.
which actually reduces the artery's ability to widen and contract properly. That's that decreased vasodilation capacity mentioned in the materials.
Precisely. And then these other cells called fibroblasts, they move in and cause sclerosis. That's the actual hardening part, the loss of elasticity.
And the really scary thing is, this whole process can be unfolding like silently for years and years without any obvious symptoms at all.
Absolutely. Often there are zero outward signs until the plaque significantly narrows the artery, restricting blood flow enough to cause issues. Or, even more critically,
What's that?
if that plaque becomes unstable and ruptures, a piece can break off, travel downstream in the bloodstream,
Oh, wow.
and potentially cause an embolism, blocking a smaller vessel further down. That's a major, major risk.
Okay, so cholesterol is clearly a huge player. The blueprint mentions something called HMG-CoA reductase. That sounds pretty technical.
It is a bit technical, yeah, but it's a really vital enzyme. It's found in the liver.
Okay.
And its main job is to help the body actually produce cholesterol. See, the liver is kind of a central command for managing cholesterol levels.
Right.
And this enzyme, HMG-CoA reductase, is the exact target of statin medications, those common cholesterol-lowering drugs people hear about.
Oh, okay, that makes sense then. They block the enzyme.
Exactly. By inhibiting this enzyme, statins effectively reduce the liver's production of cholesterol.
Got it. Okay, let's shift gears a bit to another very common arterial issue: hypertension, high blood pressure. Our info distinguishes between essential and secondary hypertension. What's the core difference we need to grasp there?
So essential, or sometimes called primary hypertension, is by far the most common type, way more prevalent.
Okay.
It's diagnosed when high blood pressure isn't a direct result of some other underlying medical condition. It just is.
Right. And secondary.
Secondary hypertension, on the other hand, has a specific identifiable cause, like chronic kidney disease or maybe a tumor on the adrenal gland called a pheochromocytoma, which pumps out excessive hormones like adrenaline.
And the really alarming thing about hypertension, high blood pressure, is that it often doesn't show any obvious symptoms until, well, significant damage has already occurred.
That's such a critical point. It's often called the silent killer for exactly that reason.
Yeah.
It can be silently damaging your cardiovascular system for years without any noticeable warning signs. Our materials outline several major negative effects. First, just the constant high pressure puts increased stress on that delicate inner lining of the arteries, the endothelium.
Leading to damage over time.
Leading to damage, yes.
And that increased resistance the heart has to pump against. That really makes the heart work harder, doesn't it?
Yeah.
Specifically, the left ventricle.
Exactly. The left ventricle, which is the heart's main pumping chamber, it has to work much harder to push blood out against that elevated pressure.
And over time.
Over time, this increased workload can cause the left ventricle muscle to thicken and enlarge. It's a condition called left ventricular hypertrophy.
Which sounds bad.
Well, ironically, while the heart muscle gets bigger, the network of tiny blood vessels supplying the heart muscle itself might not keep pace. It doesn't necessarily expand at the same rate.
Oh, I see.
So that can potentially lead to insufficient blood flow to the heart muscle, increasing the risk of ischemia or even infarction, a heart attack or heart failure down the road.
Wow. The information also highlights how hypertension contributes to peripheral artery disease, PAD. How does that connection work?
Well, by damaging blood vessels generally, including those in the legs and feet, hypertension accelerates that atherosclerosis process we talked about.
Okay.
But specifically in the peripheral arteries, this further reduces blood flow down to the legs and feet. So yeah, that seemingly subtle increase in blood pressure can have these really widespread effects. It illustrates that initial point about how something feeling off could be linked to the whole system.
And the list of potential organ damage from chronic hypertension is quite sobering. You've got heart problems, vision loss from damage to tiny arteries in the retina.
Yeah, the eyes are very sensitive.
Kidney issues where protein starts leaking into the urine. Even brain damage like hemorrhagic stroke.
Yeah.
It really hammers home how vital it is to manage blood pressure effectively.
It really does. And our materials rightly point out the crucial role of the renin-angiotensin-aldosterone system. People usually just say RAS.
RAS, right.
In regulating blood pressure, renin, an enzyme from the kidneys, starts this cascade. It leads to angiotensin the first, then angiotensin the second.
And angiotensin the second is the powerful one.
Very powerful. It's a potent vasoconstrictor, narrows blood vessels, and it also triggers the release of aldosterone.
Aldosterone.
Yeah.
That affects salt and water.
Exactly. Aldosterone makes the kidneys hold on to more sodium and water, which increases blood volume and thus blood pressure. Understanding this RAS system is key because so many blood pressure meds target different parts of it.
Like ACE inhibitors or ARBs.
Precisely. They interrupt that cascade.
And in primary hypertension, the common kind, is there a specific glitch in the RAS system?
Well, the exact cause isn't always perfectly clear, but there's evidence suggesting some people might just be more sensitive to angiotensin II,
Okay.
leading to too much blood vessel constriction and fluid retention. Interestingly, the info also notes that things like chronic stress or even certain drugs can stimulate renin release, kicking off the whole RAS process and pushing blood pressure up.
Okay, let's move on then to peripheral artery disease, PAD. We've touched on hypertension's role, but the blueprint highlights other big risk factors.
Yes, definitely. PAD is seen more often in certain groups, including African Americans, smokers, a huge factor, and people with diabetes.
How does diabetes contribute?
In diabetes, those chronic high blood sugar levels can directly damage the endothelium, the lining of the blood vessels. It just creates an environment that promotes atherosclerosis, particularly in those peripheral arteries, usually the legs and feet.
And the main consequence of PAD is that reduced blood flow, leading to that classic symptom, intermittent claudication. Can you describe what that feels like?
Yeah, intermittent claudication is basically a cramp and pain in the leg muscles, calf, thigh, buttock that comes on during physical activity, like walking.
Okay.
And then it's typically relieved by resting for a few minutes. Our materials also mention other signs, like pain or numbness, even at rest in more severe cases. Diminished or even absent pulses in the feet, maybe decreased sensation. Sometimes even nerve damage in the muscles from that chronic lack of oxygen, the ischemia.
So how is PAD managed? It sounds like it's mostly about tackling those underlying risk factors we keep mentioning.
Pretty much, yes. The mainstays are getting cholesterol down, adopting a heart-healthy diet, managing weight, controlling blood pressure effectively, and absolutely, unequivocally, stopping smoking.
Smoking seems to come up again and again.
It's incredibly damaging to blood vessels, and regular exercise is also crucial for PAD management.
Why exercise if it causes pain?
Because it can actually stimulate the growth of new, smaller blood vessels. They're called collateral vessels. These can kind of bypass the blockages and help improve blood flow to the muscles over time.
Interesting adaptation. Okay, now let's talk about something that sounds pretty serious. Aneurysms. What exactly is an aneurysm and what usually causes them?
An aneurysm is essentially a localized weak spot in the wall of an artery. This weakness allows the artery wall to bulge outwards or dilate abnormally.
Like a bubble forming on a tire.
That's a pretty good analogy, yeah. And the primary cause, as our info indicates, is often damage to the artery wall from arteriosclerosis, that hardening and loss of flexibility we talked about earlier.
And are there specific risk factors that make someone more prone to developing one?
Yes, several things increase the risk. Smoking, again, hypertension, a family history, genetics can play a role, and of course the presence of atherosclerosis itself.
And the big and dangerous rupture.
That's the major concern, yes. The weakened wall can rupture under the pressure of blood flow. The signs and symptoms really depend hugely on the aneurysm size and, critically, its location. Often they're completely silent, totally undetected until they actually rupture.
The blueprint specifically mentions a cerebral aneurysm. That sounds particularly dangerous.
It is. A cerebral aneurysm is in an artery in the brain. If that ruptures, it causes bleeding into the space around the brain, a subarachnoid hemorrhage. Very serious.
Okay. Our materials also really highlight abdominal aortic aneurysms, or AAAs. Why the special focus there? And what's this warning about a pulsatile mass, no palpation? That sounds urgent.
It is an extremely critical warning, and AAA is an enlargement of the aorta, the body's main artery, specifically down in the abdominal region.
Right.
The instruction, pulsatile mass, no palpation, is vital because if someone suspects or knows there's an AAA, physically pressing on it, trying to palpate it, carries a significant risk of causing it to rupture.
Which would be catastrophic.
Like a life-threatening emergency, yes. Prevention managing blood pressure, stopping smoking, is absolutely key for reducing AAA risk.
Got it. Okay, finally, under arterial disorders, we have aortic dissection. How is this different from an aneurysm?
It's different, though, related to aortic weakness. In an aortic dissection, it's not just a bulge, it's an actual tear within the layers of the aorta's wall. Yes. The aorta is constantly under this pulsatile stress from the heart beating. If the wall is weakened, blood can force its way between the layers of the wall, creating a sort of false channel or false lumen.
And that blocks normal blood flow.
It disrupts blood flow through the true lumen, the proper channel, and can cut off blood supply to vital organs branching off the aorta. It's incredibly dangerous.
And the symptoms described sound really intense and sudden.
They usually are. Sudden, severe chest pain, often described as a sharp, ripping, or tearing feeling, is the hallmark symptom. Patients might also look pale, pallor, have a rapid heart rate, tachycardia, be sweating profusely, diaphoresis.
And treatment.
Immediate intensive care. Hemodynamic monitoring, meaning tracking blood pressure and heart function very closely, and aggressive medication to lower blood pressure rapidly to reduce the stress on that tearing aorta.
Okay, wow. That's a very thorough run-through of arterial disorders. Now let's shift focus to what can go wrong with the heart muscle itself, starting with ischemic heart disease and conduction disorders. Angina comes up first. That's chest pain, from insufficient blood flow to the heart muscle. The blueprint outlines unstable, stable, and variant angina. Let's break down those differences.
Okay, so all types of angina are essentially warning signs. The heart muscle isn't getting enough oxygenated blood for its needs at that moment.
Right.
Unstable angina is considered an acute coronary syndrome. It's serious. It's characterized by chest pain that's either new, happening more often, or with less effort than before.
Okay.
Maybe lasts longer or isn't relieved by rest or meds that used to work. This is a big red flag. It can often precede a full-blown heart attack, a myocardial infarction.
So the key takeaway is new or worsening chest pain needs immediate attention.
Absolutely. Don't ignore it. It could be unstable angina, potentially leading to an MI.
And the symptoms described sound pretty alarming. Crushing chest pain, maybe radiating to the arm, jaw, back, shortness of breath, sweating, weakness, looking pale. What's actually happening inside the arteries during unstable angina?
The underlying cause is usually progressive coronary artery disease, that atherosclerosis again, often linked with high cholesterol endothelial injury.
The plaque buildup.
Right. Plaque is built up, causing a partial blockage in a coronary artery. When the heart's oxygen demand increases, like during exercise or stress, those narrowed arteries just can't deliver enough blood.
So the muscle becomes starved for oxygen.
Exactly. It becomes ischemic. This lack of oxygen leads to muscle hypoxia. Anaerobic metabolism kicks in, producing byproducts like lactic acid that irritate pain receptors, hence the chest pain.
Okay. How does stable angina differ then?
Stable angina follows a more predictable pattern. It's chest pain that reliably happens with a certain level of physical exertion or emotional stress.
Like walking up 2 flights of stairs always triggers it.
Precisely. And it's typically relieved fairly quickly by resting or taking nitroglycerin, which helps dilate those coronary arteries. It's more chronic, more predictable.
And then there's variant angina. That sounds different again, cause-wise.
Yes, variant angina, sometimes called Prinzmetal's angina, presents as severe chest pain, but the cause usually isn't a fixed blockage from plaque.
So what causes it?
It's caused by sudden spasms, intense vasoconstriction of the coronary arteries themselves. These spasms can be triggered by various things: stress, smoking, cocaine use, even just exposure to cold or certain medications.
Okay. Now, if this lack of blood flow, this ischemia, goes on for too long, that's when we get to myocardial infarction, a heart attack. Our info says this happens when the heart tissue suffers prolonged ischemia, leading to irreversible cell damage. That's quite a stark description.
It is cell death in the heart muscle. MUMIs are often classified based on ECG findings. An STEMI, non-ST segment MI, usually means a partial blockage.
Anastemi.
A STEMI, ST segment MI, typically signifies a complete and prolonged blockage of a coronary artery. That's generally the more severe type requiring immediate intervention.
And what's usually the culprit behind that complete blockage in a STEMI?
Most often, it's a coronary artery becoming completely blocked by either atherosclerotic plaque itself, or more commonly, a blood clot that forms on top of a ruptured plaque.
So the plaque breaks open.
Exactly. An unstable plaque ruptures, its contents spill out, and this triggers the body's clotting system. Platelets rush in, a thrombus, a clot forms right there, and suddenly the artery is completely occluded. Or a piece breaks off and travels downstream, lodging somewhere else.
The symptoms of an MI sound intense. Sweating, shortness of breath, extreme anxiety, maybe that classic clenched fist over the chest Levine sign. Paleness, crushing pain, weak pulses. Diagnosis involves the ECG, obviously, and also measuring specific cardiac biomarkers in the blood.
That's correct. High-sensitivity cardiac troponin, HSCTN, is a key one. Troponin is a protein inside heart muscle cells. When those cells die during an MI, they release troponin into the bloodstream. We can detect and measure it with a blood test. Higher levels indicate more damage.
And for a STEMI, the treatment protocol outline sounds pretty urgent and aggressive. The main goal is just restoring blood flow ASAP, right?
Absolutely. Time is muscle. The immediate priorities are oxygen, aspirin to start more clotting, nitrates like nitroglycerin to dilate vessels, pain relief, other antiplatelets or anticoagulants.
That's the crucial step.
Reperfusion therapy, physically getting that blocked artery open again. That's usually done either with clot-busting drugs, thrombolytics, or, more commonly now, by performing a percutaneous coronary intervention, PCI.
Angioplasty and stenting.
Exactly, in a cardiac cath lab. Threading a wire and balloon to the blockage, inflating it, often placing a stent to keep the artery open. Speed is absolutely critical for STEMIs.
Okay. Shifting gears slightly to the heart's electrical system, our materials briefly mention depolarization and repolarization and how these show up as waves on an ECG.
Right. So depolarization is the rapid electrical change across the heart muscle cell membranes that actually triggers the muscle to contract to squeeze.
Okay, the electrical on switch.
Pretty much. And repolarization is the cells returning to their resting electrical state, which allows the muscle to relax and get ready for the next beat. The electrical reset.
And the ECG traces these.
Exactly. The P wave shows the atria, the top chambers, depolarizing. The QRS complex, that big spike, shows the ventricles, the main pumping chambers, depolarizing. And the T wave shows the ventricles repolarizing, relaxing.
So PQRST is basically atria squeeze, ventricles relax.
In very simple terms, yes. That's the electrical sequence for a normal beat.
And when these precisely timed signals get messed up, we get dysrhythmias, abnormal heart rhythms. The info lists several key ones, starting with atrial fibrillation, AFib. Seems pretty common.
It is quite common, especially as people get older. In AFib, the atria are just electrically chaotic. They're quivering, fibrillating in a really disorganized way, maybe 400 to 600 times a minute.
Wow, that fast.
The atrial rate, yes. Now, not all those chaotic impulses get through to the ventricles, thankfully, but the ventricular rhythm is usually irregular and often faster than normal.
And the big danger with AFib.
The biggest concern is stroke risk. Because the atria are just quivering, instead of contracting properly, blood can become stagnant, pool in little pockets, especially in the left atrial appendage.
And clots can form there.
Exactly. Clots form, then they can break off, travel up to the brain, and cause a stroke. That's why most people with AFib need to be on blood thinners, anticoagulants.
Okay. Then there's ventricular fibrillation, VFib. The notes say, no blood is moving out of the heart. Incompatible with life. Shockable rhythm. That sounds incredibly dire.
It is the most dangerous arrhythmia, cardiac arrest. In VFib, the ventricles aren't contracting at all. They're just quivering chaotically, totally ineffective. Zero blood is being pumped out.
So immediate emergency.
Absolute emergency. Requires immediate CPR to manually circulate blood and defibrillation, the electrical shock, to try and reset the heart's electrical activity and restore a viable rhythm. That's what shockable rhythm means.
That really underscores how critical a coordinated rhythm is.
Then there's ventricular tachycardia, VTach, described as a rapid rhythm from the ventricles, wide, bizarre QRS complexes on the ECG. Sounds like severity can vary.
Exactly. The ventricular rate in VTach can be fast, maybe 70 up to 250 beats per minute. The critical factor in managing VTach is whether the patient has a pulse or not.
Why is VTach dangerous even with a pulse?
Because when the ventricles beat that fast, they don't have enough time to fill properly between beats. Diastolic filling time is too short. Plus, the coordination with the atria is lost. Both things severely reduce cardiac output, the amount of blood pumped out.
So how is it treated? If the patient has VTach but has a stable pulse, we might use antiarrhythmic drugs like amiodarone. If they have a pulse but are unstable, low blood pressure, confused, they need synchronized cardioversion, another type of electrical shock. If there's no pulse with the VTach...
Treat it like VFib.
Exactly. Treat it like VFib, immediate CPR, and defibrillation.
And finally, asystole. That's the flat line, right?
That's the flat line. Complete absence of any detectable electrical activity in the heart. No P waves, no QRS, nothing. Not a shockable rhythm, unfortunately. Treatment is CPR and trying to find a reversible cause.
Okay, let's transition now into heart failure. Our info starts by defining some really fundamental terms: preload, afterload, contractility, and cardiac output. These seem essential to understanding what goes wrong.
They absolutely are foundational. Preload, think of it as the stretch on the ventricular muscle fibers right at the end of filling, just before they contract. It's mostly determined by how much blood returns to the heart from the veins.
And it's something called the Frank-Starling mechanism?
Right. The Frank-Starling mechanism basically says, within limits, the more you stretch the heart muscle fibers at the end of filling, more preload, the more forcefully they'll contract. More stretch equals stronger squeeze, up to a point.
Okay. And afterload, what's that resisting?
Afterload is the resistance the left ventricle has to push against to get blood out into the aorta and the rest of the body. It's largely determined by the resistance in the systemic blood vessels. High blood pressure means high afterload.
Makes it harder for the heart to pump.
Exactly. More work for the ventricle.
Contractility, then, is the heart muscle's own inherent strength, independent of preload and afterload. The notes mention positive and negative inotropic effects.
Precisely. Contractility is the intrinsic pumping power of the heart muscle itself. Positive inotropes are things, often medications, that make the heart muscle contract more forcefully. Negative inotropes weaken the contraction.
Okay, and finally, cardiac output. That's the bottom line measure of pump function.
Yes, cardiac output is the total volume of blood the heart pumps out each minute. It's simply stroke volume, the amount pumped per beat, times the heart rate. Normally, it's around 4 to 6 liters per minute at rest for an adult.
Now, heart failure can be broadly split into systolic dysfunction and diastolic dysfunction. And the materials say both often primarily affect the left ventricle. What's the basic difference?
So in systolic dysfunction, the main problem is contraction. The heart muscle, especially the left ventricle, is weak. It can't squeeze forcefully enough to eject a normal amount of blood. The ejection fraction is reduced.
Okay, weak pump. And diastolic.
In diastolic dysfunction, the problem is relaxation and filling. The heart muscle becomes stiff, it doesn't relax properly during diastole, so the ventricle can't fill adequately with blood even if the squeezing strength is okay.
Stiff pump.
Stiff pump, exactly. And importantly, many patients actually have a mix of both systolic and diastolic dysfunction contributing to their heart failure.
Our info also mentions BNP.
Yeah.
B-type natriuretic peptide. Why is that level important in heart failure?
BNP is a hormone. It's released mainly by the heart's ventricles when they're stretched or under pressure, which happens in heart failure.
So it's a sign of stress on the heart.
Exactly. An elevated BNP level in the blood, usually above 100 pgml, is considered significant, is a key biomarker. It helps diagnose heart failure, assess how severe it is, and even track how well treatment is working.
Heart failure is also described based on which side is mainly affected, right-sided or left-sided, leading to different symptoms. Let's start with right-sided heart failure. What happens there?
In right-sided heart failure, the right ventricle can't pump blood effectively forward into the lungs. So blood backs up in the systemic venous circulation, the veins returning blood from the body.
And that backup causes?
It causes symptoms like dependent edema, swelling in the legs, ankles, sometimes even the sacrum if the person is lying down, weight gain from fluid retention, congestion of abdominal organs like the liver and spleen, making them enlarged.
Hepatomegaly, splenomegaly.
Right. Also, jugular vein distension JVD, where the neck veins bulge. And in severe cases, ascites fluid buildup in the abdomen. Think systemic fluid overload.
Okay. And how does left-sided heart failure look different? Seems more lung-related.
That's correct. In left-sided failure, the left ventricle can't pump oxygenated blood effectively out to the body. So blood backs up into the pulmonary circulation, the vessels in the lungs.
Leading to fluid in the lungs.
Exactly. Increased pressure in the pulmonary vessels forces fluid out into the lung tissues and air sacs pulmonary edema. This causes symptoms like shortness of breath, especially with activity, dyspnea, or when lying flat, orthopnea. Also a persistent cough, sometimes with frothy sputum, and general fatigue because the body isn't getting enough oxygenated blood. Think respiratory symptoms.
Okay, that clarifies the two sides well. Let's move now to valvular heart disease. First, just a quick reminder. 4 valves, tricuspid and pulmonary on the right, mitral and aortic on the left, keeping blood flowing one way.
Exactly. They open and close precisely with each beat to ensure efficient unidirectional flow through the heart chambers. Now, our info mentions rheumatic fever, possibly leading to rheumatic heart disease, RHD. Can you explain that link?
Sure. Rheumatic fever is an inflammatory reaction that can happen after a group A strep infection, like strep throat, if it's not treated properly.
Okay.
In some people, the immune system mistakenly attacks the body's own tissues, including, unfortunately, the heart valves. This damage over time can lead to rheumatic heart disease, often years later.
Okay, so an infection leading to valve damage. And the valve problems themselves usually fall into 2 main types: stenosis and regurgitation, sometimes called insufficiency. Can you quickly explain those?
Sure. Stenosis means the valve opening is narrowed, constricted. It makes it harder for blood to flow through, increasing resistance and making the heart chamber behind the valve work harder. Like aortic stenosis, making the left ventricle work harder.
Right, restricted forward flow.
And regurgitation means the valve is leaky. It doesn't close properly, so blood flows backward across the valve when it should be closed. This reduces the amount of blood effectively pumped forward.
Leaky valve, backward flow. Got it. And both of these can cause heart murmurs, right? Those extra sounds heard with a stethoscope.
Yes, the turbulent blood flow, either squeezing through a narrow opening in stenosis or leaking backward in regurgitation, creates those murmur sounds. The info does note there are physiological or innocent murmurs.
Right, not caused by disease.
Maybe due to high flow states like pregnancy or fever. But pathological murmurs point to an actual structural problem with a valve or the heart itself.
Okay. Our materials then dive into specific mitral valve disorders. Problems with the mitral valve between the left atrium and left ventricle can cause perfusion issues, stroke risk, pulmonary edema. Mitral stenosis, the narrowing, is often linked to that rheumatic heart disease.
Yes, RHD is a major cause historically, though maybe less so now in some places. But it can also be caused by mitral annular calcification, MEAC. Yeah, calcium buildup in the ring around the valve.
Yeah.
Tends to happen more with aging and atherosclerosis.
Ah, okay. So mitral stenosis obstructs flow from the left atrium to the left ventricle. What does that lead to?
It causes blood to back up in the left atrium, increasing pressure there and potentially backing up further into the lungs, causing pulmonary edema. It also reduces the amount of blood getting to the left ventricle, so overall cardiac output can decrease. The murmur is described as low-pitched, rumbling, best heard with the patient on their left side.
Okay. What about mitral valve prolapse, MVP? That seems common too.
MVP is when the mitral valve leaflets are kind of floppy and they bulge or prolapse back into the left atrium when the ventricle contracts. Sometimes this leads to leakage, mitral regurgitation. Barlow's disease, a connective tissue issue, is mentioned as one possible underlying cause.
Okay, floppy valve. Now, aortic valve disorders. Aortic stenosis, narrowing of the valve leading out of the left ventricle to the aorta. Causes listed include calcification, like aortic sclerosis with aging.
Right, wear and tear.
Rheumatic heart disease again, or maybe a congenital defect, like a bicuspid valve instead of tricuspid, that causes problems later in life.
And aortic stenosis is a big deal because it obstructs outflow from the main pumping chamber, right?
Huge deal. It forces that powerful left ventricle to generate much higher pressures to push blood out, leading to significant left ventricular hypertrophy, that thickening of the muscle.
And the symptoms reflect that strain.
Yes. Exertional dyspnea, shortness of breath with activity, pulmonary edema if it gets bad, angina, chest pain, because the thickened heart muscle needs more oxygen. You might feel a slow, delayed carotid pulse in the neck. The murmur is typically harsh, systolic, heard best at the right upper sternal border, maybe radiating to the neck, often louder leaning forward.
Okay. Lastly, the info briefly covers tricuspid valve disorders, saying they're less common. Tricuspid stenosis narrows the valve between the right atrium and right ventricle.
Impeding flow into the RV, causing systemic venous backup, yeah. It has a specific murmur, too, an opening snap and diastolic rumble, heard lower left sternal border, louder with inspiration.
And tricuspid insufficiency, or regurgitation, leaky tricuspid valve.
Yeah. Blood leaks back from the right ventricle to the right atrium. Can be caused by things like an RV heart attack or infective endocarditis, especially, the notes mention, in IV drug users. Treatment often involves valve surgery and managing any right-sided heart failure symptoms.
That gives a good overview of the main valve issues. Now, in a really interesting connection, our materials briefly touch on how cardiovascular issues can link to problems in other systems, like the GI system and the liver. A full dive is maybe for another day, but it shows how connected things are.
Indeed. It's a great point. For example, esophageal varices, those enlarged, risky veins in the esophagus. They're often a direct result of portal hypertension.
High pressure in the vein leading to the liver.
Exactly. And that high pressure is frequently caused by liver cirrhosis, which impedes blood flow through the liver, causing a backup. So liver disease leads to portal hypertension, leads to esophageal varices, a GI bleed risk.
And severe heart failure can affect the gut, too.
Absolutely. Severe heart failure, especially right-sided, can cause congestion of blood in the abdominal organs. The liver can get congested and enlarged. The gut wall can become swollen, potentially affecting nutrient absorption. It really highlights that the body isn't just separate compartments. It's all one integrated system.
It's a powerful reminder, isn't it? When one part of this intricate machine isn't working right, the ripple effects can be felt all over.
Absolutely. Understanding those connections is so key to seeing the bigger picture of health and disease.
Well, this has certainly been a truly in-depth exploration. It really shines a light on the incredible complexity, but also the interconnectedness of our cardiovascular system and just how far-reaching its impact is on our overall well-being. It's quite astonishing how seemingly unrelated symptoms can actually be intricately linked back to how this vital system is functioning or maybe dysfunctioning.
And what's so valuable about digging into this, I think, is that by gaining a deeper understanding of these underlying mechanisms, the why behind things, you, the listener, are really empowered. You're better equipped to be informed about your own health.
Yeah, maybe recognize potential symptoms earlier or understand why a doctor might be asking certain questions or ordering certain tests.
Exactly. Knowledge like this, it really is a powerful tool for looking after your own well-being.
So here's a final thought, maybe something to mull over, a provocative question for you to consider. Given this intricate interplay, all the connections we've talked about today between the heart, the vessels, other organs, what single lifestyle change do you personally think might have the most significant, the most widespread positive impact on cardiovascular health, and consequently, on your overall quality of life?
That's a great question to reflect on. There's often no single magic bullet, but thinking about the biggest levers, yeah, it's worthwhile.
Something to ponder as you go about your day.
Definitely. We really encourage you to think about the information we've shared, maybe even dig a bit deeper into any areas that particularly caught your interest today.
We genuinely hope this deep dive has provided some valuable clarity, maybe a fresh perspective on the truly remarkable and absolute vital work that your circulatory system does every second of every day. Until our next exploration.